And I love this title, From Our Shoes to Her Shoes, The Path to Successful Breastfeeding. And Dr. Ruth Petersen, who is an MD and has an MPH, is going to be our speaker. She's the director of the CDC's Division on Nutrition and Physical Activity and Obesity. You probably didn't know the CDC cared about those things. She provides national leadership in nutrition and physical activity and obesity prevention, and spends a lot of time developing policy and developing guidelines and surveillance and using epidemiology. We're all taking courses in epidemiology, but here's somebody who's making use of it and is doing behavior research. Before all this, she was in the North Carolina Department of Health. She's been a physician in preventive medicine, and she does have both an MD and an MPH, and which she obtained from the University of North Carolina at Chapel Hill. She took a residency in preventive medicine and a postdoctoral fellowship in health services research. She has been spending her life improving health behaviors and hopefully reducing chronic disease. So let me introduce Dr. Ruth Petersen.
Well, thank you, Dr. Lawrence. It's an honor to be here and to meet all of you. I am thrilled to be representing CDC. As Dr. Lawrence mentioned, I'm in the Division of Nutrition, Physical Activity, and Obesity Prevention. So when I slip up and I call that DNPAO, that's what I'm talking about. Everyone seems to love acronyms at CDC, and we are certainly not the exception. But it really is an honor to be here to talk about the perspective of how we can move forward in this country and actually globally with breastfeeding, but making sure that we keep track of the different perspectives that we need to pay attention to. And I've heard so much of that sprinkled throughout the earlier presentation, so I'm very happy about that. So today what I'd like to do in our time together is I'd like to give you an overview of CDC's contributions and investments in breastfeeding. Oftentimes I've noticed that CDC likes to stay in the background of what's going on in public health efforts moving forward, and we only forward face with our grantees. So we actually have people that we fund in state health departments, local health departments, and in communities, and we often wave our banner very strongly there, but sometimes we don't make it clear what we do and where our value is from the organization of CDC. So I want to talk a little bit about that, which is very hard for people in public health to talk about their value, so just hang in there with me. But I also want to go through, everybody in here probably helped write the 10 steps, but I want to go through the 10 steps that we're talking about implementing with the hospitals across the country with some of our many partners. But it's not just a journey to the 10 steps that those hospitals have to go through or those birth centers have to go through. I want to talk a little bit about my perspective in my own training. Actually was in OBGYN in Rochester, so a little bit of that training, what it was like to do that, and then what it felt like to work in North Carolina at the state health at the state health department, and then what it feels like at the federal level. But I also really want to focus on the journey that the individual women who are making that decision around breastfeeding about them, and I'm happy to have much of the work that 1,000 Days has done, and I'm happy that Lucy Sullivan and her team allowed me to share some of the quotes from the women. So I'll have some of my own stories, but I felt like it would be really important to have some quotes from the women that 1,000 Days worked so closely with. So when you look overall together, we can easily say that we've improved practices to support breastfeeding. And there's some great news. More hospitals are using a majority of the 10 steps. In fact, when you look at 2007 data compared to 2015 data, we've gone from 29% to 62% of hospitals that now have a majority of the 10 steps that they've implemented. The rates of breastfeeding initiation have increased, and you've seen that graph a couple times today. You'll be pleased to know I have it in my slide deck too, so you get to see it again. But it's also important, we just picked up our last state in the United States for baby-friendly hospitals, so we now have a baby-friendly hospital in every single state in the United States and in DC and Puerto Rico. So when you look at the percentage of babies that are born in baby-friendly hospitals, that's increased from 1% to 21% between 2005 and 2017. And that's just a huge, huge potential impact that we've had in this country. And we've done it all in partnership with many people. So I don't mean to imply this was just CDC, this was a lot of people. So you've seen this, like I've said, but just to point out, we've got 81% of our U.S. infants who initiate breastfeeding, and then we have at 6 months, we have 51.8% of infants in the United States that are breastfeeding, not exclusively breastfeeding, but breastfeeding. So the trend is up, and people have commented on that, and I think that we should all feel really good about that, but I think we know that we have a lot of work left to do because we're not at the 100%, which is what many of us would like to see. So what does CDC do? How do we support breastfeeding? Again, oftentimes we're behind the scenes in many things that happen. And so the team and I really sat down and talked about this presentation and what we'd like to share with you and what our work is. And the three main strategies that we work on at CDC is what you see on this slide. The first one is we really do want to improve the system of care at the hospital level. And that has to include support for breastfeeding based on our best practices and then based on implementation science across the country. Secondly, we work to improve support for employed women. And many of you, and again in the presentations, have talked about that, and we heard from Dr. Brown about his patients, about how hard that is when they have to go back to work. So what we're doing is working, again, behind the scenes on developing some of the evidence to show that you really should have best practices around the ability to improve women's support in a work site. So does she have accommodations for pumping? And again, Dr. Brown mentioned that. But also, can we build the evidence support to show that if you have maternity practices and maternity leave and increased breastfeeding support in these work sites, that our breastfeeding rates continue for a longer period of time? So the actual science behind that is really important. So our goal is really to make sure that when a mom decides to breastfeed, that she has the supports in place to initiate and then continue as long as she wants to meet her breastfeeding goals. So that's really what we're about, sort of behind the curtain. And again, I want to show the commitment that CDC has had over the years to supporting moms when they decide to breastfeed. And really the support continues from the very beginning with the United States Health and Human Services document, which was the blueprint for action on breastfeeding. How many people in the room helped with that blueprint? Anybody here today that helped with that? It's great. So thank you. You guys started this. We appreciate it. And what a great, great, great thing to have. I didn't realize the importance of these blueprints and these federal agencies committing to something until, again, I see that now from the lens I have at CDC. So that started in 2000, and then in 2003, there was a big decision reached that CDC should try to monitor the maternity practices. And so what was launched from that work and that vision, and again, back to the blueprint, was what we fondly refer to as the MPINK survey now. So the MPINK survey, planning started for that in 2004. It stands for Maternity Practices and Infant Nutrition and Care. And it's really a biennial national survey of the maternal practices that are in hospitals and birth centers, looking at facility-level data so that CDC can send those hospitals and birth centers their specific sort of scorings on how they're doing with the practices and the policies that we now know should be the standard. So you see in the grid here that the timeline, that what we've been able to do is continue those surveys every 2 years, and that the different facilities, again, get those reports. So you see that in 2007, you see it in 2009, 2011, 2013, and 2015. And then down at the bottom on the timeline, I want to point out, because a couple people mentioned healthy people the Healthy People 2020 initiatives for breastfeeding and what those goals are. Those goals were only established in 2010 for the very first time. So when you see the 2020 goals that were established in 2010, again, that was the work behind the scenes of probably some more people in this room about getting that rolled up into the Healthy People 2020 measurements. We're funny in public health and in surveillance and in science. Until we have something that is very visible, sometimes the problem doesn't exist. So having something included in the Healthy People objectives is a key milestone in actually tracking an issue. So we were happy that happened. The other thing that's interesting, you see in the bottom right of the timeline, two specific things that are mentioned, and many of you probably know them from the different titles, but both of these, the Best Fed Beginnings, which was 2011 to 15, and the Empower Breastfeeding, which was 2014 to 2017, was really the baby-friendly hospital initiative sort of beginnings. And it was through this work that CDC is able to support that effort, again, across the country and in our territories. So it's really, as you all know in the room, but it's a quality improvement system with some guidelines about how you make sure that you implement the 10 steps, which I will talk about as we move forward here. Again, not just to tell you what they are, but to tell you how the different perspectives play into it. So here's an example of the MPINC data that we have, and you can pull this down off of our CDC website and off of the DNPAO website. The darker the color, the higher the MPINC score. And so you see that the darkest pink, I hope you can see the tone. The three darkest states are Delaware, New Hampshire, and Rhode Island, which all have scores over 90. The exciting thing for us is, like I said, everyone now has a baby-friendly hospital across the country. So that's great improvement. The other thing, again, that MPINC does is by sending this out to individual facilities, everybody's competitive. I mean, you can't get away from it. I mean, we get now hospitals that call us and they want to know what their counterparts got as their MPINC score. So everybody wants to know, because this suddenly becomes a marketing technique that you have to talk to your community. And someone mentioned the IRS regulations and community benefit, and all this stuff starts to roll up into those community-based needs assessments. And so competition may be a beautiful thing here. So we're moving towards that. MPINC isn't the only sort of surveillance or monitoring system that we have at CDC. And so I just wanted to give you an idea of sort of the breadth of the surveillance that we do across the country, because different surveys are used to get us different pieces of information. And this is all available, and the people at CDC who work with this data would be happy to work with other folks if you'd like access to this. So please don't hesitate to get in touch with me later. The National Immunization Survey, this isn't something that generally people understand we have breastfeeding questions on. They were added again in 2001, so that's really exciting for us. MPINC I've mentioned, which is the census of all birthing facilities, and it looks at maternity care practices. We also have the Infant Feeding Practice Study, which is a cohort study of women from their third trimester through their first year of their child's life. And then they reconnect with these families at 6 years of age. So this is really important data for us to have, again, from a surveillance model, to see not only what's happening with breastfeeding, but that transition, that critical transition in early child nutrition that CDC is really, really working in, again, with 1,000 Days On, and how to message some of those best practices out to moms. Then we also have a Summer Styles, which was formerly called Health Styles for some of you that may know it by the Health Styles term. This is interesting because we want to make sure we're not just a bunch of scientists sitting around at CDC coming up with numbers. So we want to make sure we keep paying attention to what are people really thinking in their community. So what are the public opinions of people about breastfeeding, and what are the public attitudes and beliefs about breastfeeding? Because if we don't actually pay attention to that, and again, I've heard that in a lot of the presentations today, so I think that we're all preaching to the choir a little bit here, but some of those messages that we get from that data really help us advise, again, our states and our grantees and our local communities about how they might want to think through something differently, or how they might want to ask more in-depth questions in their community. And again, I keep mentioning 1,000 Days, but the work that 1,000 Days has had drilling down into some of the community attitudes about this is now data that we use to help our grantees understand how complicated it is. So in addition to the surveillance work and the science work and the grantees TA work that we do, CDC shines on their distribution of translation of evidence-based into practical sort of campaigns or vital signs or MMWRs or journal articles. And these are intended for different audiences. So we try to pay attention to how the science can be translated in a way that's meaningful for people to get some action done. So hopefully, if you haven't seen some of these, you can find these again on the website. And briefly, and again, you guys all know this, so I'm preaching a little bit to the choir, but we know from all our data that moms don't breastfeed as long as they intend to breastfeed. So that we've got a 2013 study that shows that only 60% of U.S. mothers said that they breastfed as long as they intended. And again, it was so great to have the health equity talk before this. Achieving equity in access to breastfeeding support needs to be a vision and a mission and something that gets us to work every single day, or we're not going to make it happen. And you've seen, again, these numbers, and so I won't go through them all except to point out, again, this is the data from 2013, which shows that the disparity, the blue is the white, the purple is the black, and then you can see the 18% difference in initiation here, the 12% difference in whether or not they're breastfeeding exclusively at 6 months, and then the 16.8% difference between whites and blacks at 12 months. So again, we have made tons of progress, but we have a lot of challenges we need to address to help women with, again, their goals of initiating breastfeeding and then continuing breastfeeding as long as they would like to. So again, a few perspectives. So here are the 10 steps. And what I want to do is talk a little bit briefly about the 10 steps, but I want to put this in more of a story, so a journey. So we can't just expect people to initiate all of these 10 steps without some heartburn. And so I want to give you a perspective a little bit of my role, not only when I was a young physician, but also then becoming a state public health leader and then now moving to the federal level. Because each one of these perspectives that I brings anxiety to some of these 10 steps, but also it's the only way for me to tell you the story about how we might be able to fix this for some other people. So the 10 steps are broken in the way I'm going to present it to you. The first 3 steps are really about the healthcare system prenatally. Step 4 up to 9 is about making mothers successful in the hospital, and step 10 is when she goes back to her community. So let me walk through that a little bit in the first, in that framework. So again, the first 3 steps are about setting the stage for success within that healthcare system. Step 1, and it was mentioned today, and I love already that somebody talked about that, you need to have the written policy that's routinely communicated to all staff. You need to have all your healthcare staff trained in the skills necessary to implement the policy, and then you need to inform all pregnant women about the benefits and the management of breastfeeding. All of those words are so important. I could talk for an hour about each one of these steps because those words aren't just random words. I mean, when you think about training all healthcare staff, all is so critical. You can't have someone else who's not trained in the same policy. Having a policy that's routinely communicated. It doesn't help to have a policy up in the C-suite. It helps to have the policy routinely communicated. So let me talk through some of my perspectives. So my staff had a really good time doing this little picture of me as a young person. So that was pretty cute. But it is, so what were some challenges that I faced when I first started out? First of all, I went to the University of Rochester. Dr. Lawrence is from there, and I have to tell you that I never learned anything about breastfeeding. Ever. So what's the mismatch between a healthcare system that has true leadership and then an intern coming into a program? So didn't learn anything about breastfeeding, how to counsel about breastfeeding. When I did my prenatal work as an intern And then when I worked in a health department as a clinician, I didn't have the computer problem that Dr. Brown talked about today, because we had clipboards with 10,000 pieces of paper on them. So I'm looking at the clipboard. It doesn't say, do you want to breastfeed? Are you going to breastfeed? It says, infant feeding plan. Discussed, yes, no. My question as an intern to so many women, what's your infant feeding plan? I'm sorry, what is that? What a horrible question. You know, that wakes me up in the middle of the night some nights. That's really horrible. But what's really horrible, because I can make fun of myself for that one, but what's really horrible is I didn't understand what it was like to be a pregnant woman in rural New York State who didn't have a job, who didn't have enough food, who was getting beaten by her partner, and who was addicted to cocaine. And I bet you 60% of my patients fit into that category. And I didn't get it. Now, that's just embarrassing. But I will say, I recovered a little bit here. So I moved into other healthcare systems where there were stronger policies and there was stronger training about that. And I did site visits. I did home visits to see these mothers. And I saw the plywood in front of their refrigerator door that they couldn't get their wheelchair over because their floor had collapsed, and they couldn't get their insulin. When I'm getting mad at them about, why aren't you taking your insulin? And then I see their house. So, you know, you just keep learning. So challenges for the healthcare system that I would give you for those first 3 steps is really training all staff that I worked with had not happened. Because if I talked to one person on the staff about breastfeeding, what should I say? I would get one answer. And if I talked to another person on the staff, I would get, oh, don't worry about that. It's, you know, that's her choice. You don't need to talk to her about that. So just, we have a lot to work on. Again, from the woman's perspective, here is a quote that isn't necessarily about the prenatal period, but listen to what 1,000 Days has found from Tanya. When I had him, I had no milk. When the milk came in, I did it for 4 weeks. Then the milk stopped, so I stopped. I would have breastfed him as long as milk came out, but it was my first baby, and when the milk stopped, I thought, oh, maybe it's time to stop. So if Tanya had heard from her physician and her care providers and the wraparound services during prenatal care that are afforded to women because of our system that we, yes, still have, even though some people might want it to not be there, she might have known that there were going to be difficult times. She might have known it wasn't always going to be easy. And Dr. Brown was a great example of changing up postpartum care to make sure that Tanya's of the world would get that information. But Tanya should have had that information way back before she went into the delivery suite to have that happen. So step 4, 5, and 6 begin the process of what happens with preparing mothers in a hospital for a successful journey. So I have 2 boys, they're 25 and 23, and I have to tell you that the hospital experience I had with both of them was incredible because both my husband and I worked in the hospital. And we knew everybody, and it was one of the most joyous times. And when I said to him, get me out of here, I'm done now, he went and signed my birth certificate because the physician on call couldn't do it, because it would have taken another 8 hours for someone to come back around and sign my birth certificate. So I have had like the best experiences in hospitals, but not all women have had them. And I've delivered some women in hospitals that were not having good experiences. So what should hospitals do? Help mothers initiate breastfeeding within 1 hour of birth. Show mothers how to breastfeed, and then make sure that infants aren't given food or water that's not medically indicated that would interfere with the whole initiation of breastfeeding. So again, some perspectives and challenges that I faced, not from my personal deliveries, but from the system of care that I'm working in. Let me switch you now to where I'm the state public health leader. So I'm not the young, totally inexperienced doctor who knows nothing about things. Now I've actually had some children, and I understand that there are people in the world that live in horrible conditions, have horrible mental health conditions, have substance use addictions. I mean, I can go on and on. So I'm a little bit now bitter about the way the world is treating people. And how does that help me? Well, it helps me because I am going to go into that hospital system in North Carolina, and I'm going to talk to the lead of the hospital association. And I'm not leaving until he looks at me and says, breastfeeding is my most important thing. And I'm determined. And I go in there, and guess what? That's not his most important thing. And I can't believe it. I am stunned. And so we finally get to a level where we can agree on something. And the level we agree on is asthma readmissions for children. So I take that as a win because as I'm in public health for the state of North Carolina, I'm concerned about that too. But what I do is I know that I can work with him on that initiative, show decreases in asthma admissions for children, and then he's going to like me the next time I come back around and talk about how we can change your policies in your hospital system across the state of North Carolina to make sure that I don't get in trouble with CDC because I promised that you would do that. Because at that point, I'm funded by CDC to do that work in North Carolina. Well, what's interesting about my challenges I face are the same that the healthcare system faces in these steps. They do have competing demands. They do have the need now to participate with community needs assessments. And while that's critical, not every community is going to come forth and say to their hospital administrators, breastfeeding, that's what we're worried about. Their children are going to prison. Their mothers don't have employment, they don't have places to live, they don't have substance abuse treatments, they don't have mental health facilities, they have competing demands too. So again, how do we make sure that we can continue with 4, 5, and 6 and help the hospital systems? But again, let's not forget the mother in all of this. So what about a new mother's challenges? Again, listen to this quote. When I had him, I was still in high school. It was complicated because I had to leave class to go pump. I had to go to the other side of the school just to pump. I had to walk back to another side of school to put in the refrigerator. I was missing out on a lot of stuff. So I had to stop breastfeeding and just give him a bottle. Okay, I'm sorry. Really? This poor person didn't know that she was going to have to do some pumping at school, and it was going to be hard, and that refrigerators were going to be on the other side. Okay, we should have told her that. I didn't tell her that when I was a doctor and didn't know about it, but I was getting smart enough to know that everybody should know to tell this child who is having a child, there's going to be some really dark times for you, but let me tell you about the IQ that your kid's going to have, or the health that the kid's going to have, or the missed work days you're not going to have, like Dr. Brown did. I mean, why can't we all be Dr. Brown? Why can't we have all physicians be Dr. Brown? Let's have that happen. And he's left, so we can put him in charge of that. It'd be perfect. But again, what all this shows is that we really have an opportunity that we're missing to educate women about how hard this is, not only prenatally, but while they're in the hospital, and all staff could be trained on this, and we could look at what makes this poor, poor new mother's life so hard. So 7, 8, and 9 really continue with the healthcare system and what we should be doing to implement, to make a woman successful as she moves through the hospital. And again, we've talked about some of these today: rooming in, encouraging breastfeeding on demand, and making sure that no pacifiers or artificial nipples are given to breastfeeding infants unless there's a critical need for a medical procedure. So that's great. So let's all try to do that. Let's all try to do all those steps. But now I'm going to switch to the federal level. This is what my staff thinks I look like at the federal level. That cracks me up. So here I am now looking across CDC and looking at the 10 steps and what can we do to implement breastfeeding successfully in the country. And everything keeps changing because there's always new evidence. There's new surveillance. There's new research, even the stuff we've learned today. There's always new best practice recommendations, which is exciting. So now at the federal level, what we're trying to do, as evidence and recommendations expand, we're committed to incorporating those new recommendations and those new standards into practice. So here you have the framework of the 10 steps. You have people becoming baby-friendly hospitals. You have people who aren't going to do the 10 steps and they aren't going to be baby-friendly hospitals, but they have room for improvement. But we have to translate all of that new guideline information. And, you know, again, people in the room, people that worked on the AAP clinical report that just came out in 2016, and it talks about safe sleep and skin-to-skin care and how those things aren't necessarily opposite of breastfeeding. We can do those things safely together, and we can have safe implementation in hospital settings. Again, we're going to have a new MPINC survey that's coming out, so that's going to be new information. We've changed the MPINC survey to represent the new best practice guidelines so that we're going to start to see now how hospitals are picking up these new recommendations and best practices. And then we have an upcoming MMWR that's actually looking at the disparities across our states in the rates of breastfeeding. So we're going to get a little bit more information to states about where they stand. That will be out in July compared to other states, which again is important, not because we're trying to make people feel bad about themselves, but it's to give them the ammunition that they need to go to their decision makers and try to leverage some local resources, not only from their hospital system, but from other community providers that care. Foundations care about this. Your legislature cares about this at some times. So just an opportunity to have people continue to implement these steps better. So the last step is really one of the most interesting in new partnerships. So this is about a woman transitioning back into her community, and it's about finding ways to support her continued breastfeeding in a way that's culturally relevant to her, with resources that she likes, that aren't 400 miles away, and they're not just a name on a piece of paper that somebody writes her at discharge. We talked earlier about centering, so centering is a very important process. We also talked about the need for lactation consultants at the practice level and in the community level. We work with our grantees to try to help them figure this out. So again, CDC is giving flexibility to states to try to develop this capacity, but it's hard. It's really hard. So challenges that I face now at the federal level is that we actually have a great need for women to be able to go out into the community and be connected to someone they trust. So we heard even from Mrs. Pence about how she couldn't turn to her own mother to get advice. It had to be her mother-in-law. That happens again and again and again in many communities. So who can help them, and who's going to pay for it? So again, earlier today, we heard about a practice setting. The first person they let go is their lactation consultant because they can't justify it. So they can't justify the expense. So then how do you work with people in the community who have even less funding than people in the healthcare system? So how many hospital systems have I talked to recently? Too many, who say, I'm just going to write a referral and they're going to take care of it at the community level. I'm sorry, who's the community level? Who's paying for that? So what you have is you have a bunch of incredibly motivated, often lay health advisors or community health workers who are trained in their states in different ways, with different certifications, with different kinds of information, unless you're a state that's set up a very formal one. And those individuals dedicate their life to going into the community and giving information. So I'm sorry, we're building step 10 on volunteers who don't get any payment to go do their work. So I'm not saying that's every community situation. I'm just saying our grantees tell us a lot. That's their total situation. So how do we link? What's our challenge? How do we link seamlessly to services in the community when that woman needs help? And what if the help is at 2 a.m? You know, that's about the time you kind of crack. You know, and if you don't have 1-800 breastfeeding set up, you know, it is not going to go well. So we have a lot of work to do, I think, with this and building capacity. And again, what about a mother's challenge? He didn't latch too well, and it hurt so bad. I said, forget it, I'll just pump. It's hard. It's definitely commitment. Yes, it's definitely commitment. And the thing about commitment is it's the easiest to do when someone's really helping you through it. So we haven't quite figured that out yet, I don't think, in this country, and I'm looking forward to you guys telling me how we have figured that out. Oh, my slide didn't work, darn. So anyway, this is supposed to be a fancy little thing where the background is how our moms are technically our superheroes, but even superheroes faced obstacles, and it's important that we realize that. So what then the spin in here was the mom. It's important that we as clinicians and public health professionals really help them before they fall through the cracks. And then she was supposed to fall through a crack. So my person who spent like 20 minutes designing the slide, who came down and told me about it, is going to be so bummed. But anyway, it was really cool graphic. But it is important. I don't mean to be laughing about this very important point, but really moms are at the center of it. And those moms aren't like us. So they weren't like me when I was a new graduate and I was saying, well, of course you should breastfeed, or what's your infant feeding plan, or whatever goofy thing I was going to say. Because they do all have different contexts. And the social determinants talk was really helpful, because that, again, is something we try to remind ourselves of. At the science level, the data that we have is really important, but the data is a data point. There's always people behind the data. So that's really important. Questions, comments? I'd be happy to take anything from folks. Appreciate the time.
Hi, I'm Jessica Lee from the Center for Work-Life Law at UC Hastings College of the Law. I have a question and then a bit of a comment. My question is, for those of us who are working directly with these new mothers, it's always a challenge, at least for me, to have the conversation about those really serious challenges she may face, while also putting that shiny spin on it and encouraging her to not be afraid of embarking on this endeavor. So I'd love to hear your thoughts on how to best have that kind of scary conversation while still, while not setting up those walls in front of her in a way that might discourage her from breastfeeding.
Well, there's probably 3,000 people in the room that could answer that question too. And so that, I think, is a great way to frame the whole issue that we have to face. Because if her issues are not feeling any hope or not having a place to live, she actually isn't going to hear you talk about breastfeeding. So as anyone in the medical community or in the public health community, I don't have the tools generally to get her a place to live or employment or hope. So breaking it down into steps and then seeing that person again, almost like a motivational interviewing technique, is where we sort of landed the airplane in many circumstances where I've been in that. So you break it down into pieces where you outline what her biggest problems are, and then you break it down into steps about what either you can do or what one of your partners can do. And I didn't emphasize partners enough, so let me back up and talk about that, because it's part of any kind of a system that's going to help her be successful can't just be the health system or the public health system. It has to be housing, it has to be education, it has to be the legal system. And you have to have those people on speed dial. And women actually just become someone you pick the phone up and call your best friend in the criminal justice system because her son, you get into all of this mess. It's messy. I wish I had a really easy answer. It's just messy. And I think it's what draws people who are interested in helping people with hard problems to this field. So I don't think I really answered anything, but it's a great question.
But it is a comfort to know that it's messy
Yeah.
for all of us.
It's very messy, yes.
And just one thing, I wouldn't be able to sleep at night if I didn't bring this up. I run an initiative called the Pregnant Scholar, which is focused specifically on helping new mothers who are students. And so I saw that example, and I needed to wave my hand.
Good.
One thing that I hope everyone in this room can take back with them is that that student is covered by Title IX and should be receiving accommodations. So if you have to miss class to pump, they should be making sure that everything you miss, you're provided so that you're not missing out on your educational opportunities just because you have to take some time away for breastfeeding.
That's great that you shared that. Thank you so much.
Hi, I'm Andy Belfort from Boston. Great talk. I wanted to ask you specifically about disparities in breastfeeding and what the CDC is doing. And there's this interesting pattern that we see in a number of perinatal health outcomes, whereas the overall numbers start to improve, the disparities either don't change or they actually get wider. So preterm birth and infant mortality are good examples. And the point that you made about now every state has a baby-friendly hospital made me think, well, what if that baby-friendly hospital in every state is the hospital that serves the upper echelon, the most advantaged population? Is that kind of approach actually going to worsen the disparities that we see in access to good maternity care practices? So I'm just curious what the CDC's view is.
Yes, so that wakes us up at night. We worry about that tremendously. And what we'll do now that we have a hospital in every state. And with our health equity focus, which is something we take very seriously, is we're going to look at those places with our MPINC data, the hospitals, and then the highest rates, not only of infant mortality, but when you look at the longer term vision of chronic disease, because again, we're not just about good nutrition and increased physical activity for the fun of it. We're actually doing that for overall well-being, but then the prevention of chronic diseases. So we'll map those out. And then what we've got to figure out how to do is target those hospitals in those areas where those needs are the greatest, and then figure out how we're going to evaluate that to show whether or not that's really working. So again, I keep mentioning, so yes, we're working on that, and hopefully you'll see that coming out in the next 18 months, because it'll take us a while to get there. But one of the things that we struggle with too with our grantees, so we've just been fortunate to take over the REACH grants, which is the Racial and Ethnic Approaches to Community Health, which is a grant program that Congress has funded since 1999 that just moved into DNPAO. And those grantees are able to do their own needs assessment and then tell CDC what they'd like help with. And then we provide the technical assistance around what they've selected in a particular number of choices. So breastfeeding is one of those areas, so it's where we work on the areas where the highest disparities are and try to address that with the help of the community. So it's not us telling the community what they should do about it, it's listening to them, tell us that's one of their problems, and then helping. So I'm hoping what CDC is trying to do is look at the hospital data, just the way you described it, target those hospitals to be baby-friendly that are in those high-need areas, but then work with the communities to work at the community level as well. Thank you.
Hi, I'm Cindy Clapp from WIC in Los Angeles County, and I just wanted to say I loved your presentation and the things that you were talking about. And when you were talking about Step 10 of the Baby Friendly Hospital Initiative, just saying that at WIC, a lot of times our moms don't come in to enroll their babies
Right.
or get support until 5 weeks or 6 weeks. So we are out there, and we too, kind of work in our own silo and are trying to extend our hands to the hospitals and the healthcare providers, saying, please send your moms in. And although we don't have all the answers by any means, we are working on, the breastfeeding and the paced bottle feeding, and the health for the mom and the birth control stuff. So things that are important to the moms. In some sense, we have some of the resources, and we do have the funding through all of our tax dollars, and have some of the answers when, the moms can't afford to come back to the healthcare provider for another visit. We have a scale, we have a nutritionist, and in a lot of cases, we have a lactation consultant. So please encourage them to come our way too, and, we would love to be working, with all of you guys too, to have better health outcomes also.
That's great, thank you. And I think we had the great discussion too about WIC today, and I think Dr. Brown said, it's always everywhere, and I think Jerome went, it's not quite everywhere yet. Let's not say everywhere, but it is in some community. Cooperative Extension is another entity in some states that's picked some of that education up. So thank you for your comment. Yes.
Hi, I'm Katja Pigo from the Maternity Care Coalition in Philadelphia. And I appreciate that you mentioned Step 10. We are a community-based organization, and we provide in-home lactation support, mostly through CLCs, and we also train breastfeeding peer counselors and doulas. And we have a problem because we have a problem with sustainability of services. And the situation what we right now experience is that Medicaid healthcare providers actually call us and refer to us their patients. And they are not paying for it.
Right.
They are not reimbursing us, but we are a reliable resource in the community. So it's a real issue because those women need the support, and nobody wants to pay for it. So it would be great if the CDC would, really look at that and see how we can develop that support network.
Right, so it's the reimbursement for that, and ACA was a great step forward in at least naming it. The problem, and we got into this in North Carolina, is you have to have a specific MOU with your Medicaid delivery system at the state level to set those reimbursements, and that requires oftentimes that they need a waiver at the state level. So for states that chose not to expand Medicaid, there was little appetite for doing that, which was the case in North Carolina. So CMS is actually more of a partner with CDC than I knew, which is a really nice thing for me to be able to say. And I am really pleased with how we're having discussions around some reimbursement strategies just for this reason. And it's not just breastfeeding that the community takes the burden on. There's many other areas that community health workers and lay health advisors and doulas do for the community that should be packaged as a prevention package. And there should be a higher level sort of payment system to recognize the return on investment. So that is a discussion right now. Politically, it's not a discussion that's getting a ton of traction. There's the accountable community health movement. That's also something that CMS is really pushing. And for people who are in states that have SIMS grants, you should talk to your SIMS grant people, because the SIMS grant recipients in your state through CMS have more flexibility to set up prevention payment plans. And so I'm not sure if you have that in Pennsylvania. I'm just not sure about the state-by-state variation. If you don't have a SIMS grant, it's just worth having an overall conversation. Again, not just with yourself going with breastfeeding. Go with your chronic disease director from the state. I mean, go with somebody who can make a plea that it should be a prevention cost. And it's a journey, and it's hard, but it's entertaining, and sometimes it actually works. Some states have done this really well.
Thank you.
Mm-hmm. Great. Well, thank you so much.